An estimated 2 million Americans experience traumatic brain injuries each year. Such injuries occur every 15 seconds. While thousands die each year from their injuries, millions more are part of a silent epidemic. These injuries are internal and usually don't show on the outside. Brain injury has deep, tragic, and profound implications for the injured and their families and friends. It's common for survivors of brain injury to lose their jobs, homes, become bankrupt, and fall out of relationships with loved ones. A brain injury can happen to you or me at any time. Please listen carefully to the information in this program in case this sort of tragedy strikes you or a member of your family. Today's speaker, Dr. Jam Dejar, refutes the commonly held assumption that trauma from a severe brain injury must automatically result in tremendous disability. Aggressive intervention to prevent brain swelling and oxygen starvation dramatically improves outcomes. Quick action by trauma personnel can reduce secondary injury and the inadvertent death of healthy brain cells. It's with great pleasure that we welcome our inaugural speaker in the Brain Injury Speaker Series. Dr. Jam Dejar is a practicing neurosurgeon in New York City and a strong proponent of aggressive approaches to treating traumatic brain injury. You are a graduate of Cornell Medical School and have both MD and PhD degrees, and you are a graduate of UCLA as well for your master's and bachelor's degree. I understand that you're president of the Brain Trauma Foundation in New York, which is an organization that works internationally for improving outcomes for brain trauma patients, and that you've had specials on Nova, and you've appeared on several national television programs. And in 1996, in particular, you received a great deal of press for saving the life of a woman who was severely beaten in Central Park in New York. So thank you for coming to us from New York, and please help me welcome Dr. Ghajar. Would you spend a couple of minutes talking about your organization and the guidelines that you helped develop?
Right. I did my medical training and neurosurgery training, and I happened to invent a device in neurosurgery, and we were using it on patients that were in coma from head injury, and I saw they were getting a lot better, and not to say that this device actually is a treatment, it just helps in a certain treatment. I wasn't alone on this. There are obviously a lot of neurosurgeons that are very interested in improving outcomes for head injury patients. We got together, and the Brain Trauma Foundation funded all these guys coming together, and the American Association of Neurological Surgeons was involved with us, and so we worked together, the Neurosurgery Organization and the Brain Trauma Foundation, and we reviewed all the scientific evidence in traumatic brain injury and saw what works, what doesn't work, what's a good study, what's a bad study, and we came out with the guidelines. We got it approved through the American Association of Neurological Surgeons. The American College of Surgeons uses it actively, and the World Health Organization also was very interested in promoting it. So we repeated the survey 5 years later. Actually, the reason why this whole thing started was 10 years ago we did a survey of trauma centers and found out that they weren't following the most up-to-date medicine. And we just did the survey, and not much has changed. There's a gap between the scientific knowledge and the application of scientific knowledge. And there's no real mechanism, if you look at science and the application of science, no mechanism for getting that done, implementing scientific studies. Somebody writes in a journal article, New England Journal of Medicine, about how to lower your blood pressure and good outcomes. What's the mechanism that doctors then recommend that therapy? There's no connection. And so now we're looking at, with the national organization, we're looking at, well, how can we change the system so that if you have a severe head injury and the ambulance people recognize severe injury, maybe you should be taken to a trauma center that's equipped, sees head injury all the time, and knows what to do, has rehabilitation there. You have it all to one place. And maybe that's the way to go. But the problem is that you got to do, every state has a different trauma system, or it doesn't have a trauma system. And it's a real hodgepodge system. And that's what the foundation's for, to provide the framework to continually bring the message out to trauma centers.
How common is traumatic head injury, and what is meant by the expression secondary injuries?
Traumatic brain injury is, I mean, the problem with trauma, people think of emotional trauma as opposed to external force. And when we doctors talk about trauma, we mean an external force applied to you that causes an injury. And the most common external force that can be applied to you is your car. And so car crash is the most common form of trauma. In children, they're usually hit by a car rather than being in the car. So in kids, they're often pedestrians. But in every age group from 1 to 45, traumatic brain injury is the leading cause of death and disability. A lot of people don't know that. They think, well, it could be some cancer or stroke, but that usually occurs in older age groups. In young people, it's accidents. And the trauma surgeons have done a great job in saving people's lives in terms of preventing hemorrhage, things like that. And now we're left with survivors that had brain injury. And this is where the whole concept of secondary brain injury. The primary brain injury, the first brain injury is the accidents, your head hitting the windshield or the pavement or whatever. And that causes some shearing, some brain damage, and that may or may not be reversible. The real problem is that, and that's one set of problems that leads into prognosis because you have to take that into account. The real problem is that after that injury, just like you get your finger slammed in a door, it swells up. And the brain swells up like any other organ that's injured. And the problem is that our brain's in our skull here, and it's rigid. And if it swells a lot and the pressure gets very high, not enough blood and oxygen can get to the brain, and the brain suffers permanent damage. So our goal in neurosurgery for traumatic brain injury has been to try and reduce the pressure. And we have lots of ways of doing that now. We're very good at it. And actually, one of the leading proponents of traumatic brain injury research and treatment is right here at UC San Diego. Dr. Larry Marshall was a real pioneer in this area and has led a lot of innovations in traumatic brain injury. But neurosurgeons, intensivists, nurses, ER physicians, pre-hospital EMS workers, we're all trying to reduce the damage that occurs after the primary injury, and that's called secondary injury. And we lots of ways of doing it. We can talk about that, but the main goal is to try and reduce that, and then you're left with a primary injury. Now, if it's not extensive, people can make a reasonable recovery. But if the primary injury is extensive, in other words, you have parts of the brain that are damaged that are responsible for being awake or critical functions, that's what you got. And then you get into rehabilitation, which is in a whole other area of trying to deal with whatever injury occurred at the time of the accident, whatever secondary injury occurred.
In your experience, in the cases that you've treated, would you venture a guess at the percentage of the injury that occurs at the time of the trauma, and what percentage results from, I guess, not handling the treatment
Right.
in an effective way?
It's difficult to answer the question about what percentage is primary and permanent, and what percentage is reversible, or and I know from the people that come in, young people that come in the emergency room who are in coma. It used to be that in the 70s, close to 60% of those patients would die. And then gradually in the 80s and 90s and even now, that death rate has dropped dramatically. So it's now in the low 20s. So the chance of somebody dying coming in now is low 20s. Now it depends upon how severe the injury is, but in general, it's gone down a lot. It's gone down a lot because we have organized trauma systems, we have the ambulance people know how to resuscitate properly, and we have very good intensive care units and neurosurgical care of these patients. So it's a dramatic decrease in deaths. Now, if you look at compared to cancer, it's actually gone up a little bit. If you look at head injury, we've actually done very well in terms of saving a lot of these young people's lives.
You speak of coma and outcomes being better in terms of death than a few years ago. Are the outcomes also better for long-term functioning?
Well, all the studies have shown that what we're doing is if you look at severe injury, people in coma that come to the hospital, about 5 to 10% end up in that group, vegetative permanently, severe disabilities. But if you if you look at the death rate that's dropped over those years that I told you about, from 60% down to 20%, all those people are shifted into a good outcome group. Now, in neurosurgeons, a good outcome is you walk out of the hospital. If you talk to physiatrists, you know, and psychiatrists and people in the rehabilitation therapists, they'll tell you that, yeah, they walk out of the hospital, but they're not. That's not a good outcome.
Yeah,
it could still be a bad outcome. So neurosurgeons have done a good job of saving the lives and parking them into an area where they could make a good recovery in terms of rehabilitation. So we're happy that, and I think the reason is because they're mainly young people. If you look at the peak of head injury, it's mainly in the low 20s. They're kids, basically young males, between the age of 18 and 25. They have too much testosterone, they get into a car accident, boom, things happen. So, so if you're young, there's a tremendous potential for recovery.
Would you say that brain injury is permanent? Does a person ever recover fully from brain injury? And if not, what sorts of disabilities are associated with brain injury?
I think you can have permanent or irreversible brain injury, but I think you can have reversible behavior or manifestation of what the brain is. In other words, you can have an injury of the brain that leads immediately to disability, but then over time the brain can reorganize through circuitry or whatever to have, then you can call it reversible. So the behavior can be reversible. The injury itself can be irreversible, but the brain can reorganize. So it's traditionally thought there are areas of the brain that if you get a brain injury, you know, that's it. I mean, especially in the brainstem. The upper brainstem responds for wakefulness, and in the thalamus, where really it's responsible for you being awake. If you get both sides of those structures being injured, the chance of you making a good outcome are very low, because it interferes with you being awake. Whatever function you have, you can't do it because you're not wakeful enough.
The nature of traumatic brain injury probably is a little different than the nature of a brain injury from a stroke or other causes. Would you distinguish what's going on in the brain that makes a traumatic brain injury often a sort of a different category?
Yeah, well, stroke is a sudden onset of a blood vessel event. Usually, that's a cause of it. Usually occurs in older age groups, and it can lead to very similar kinds of outcomes as head injury if it involves a lot of the different parts of the brain. Sometimes strokes can be very focal. They can be just for your speech area or your arm strength or something like that. But sometimes a stroke can be extensive, so that what you see in terms of the global problems in head injury, you'll also see in stroke.
Brain injury survivors who have traumatic brain injury often experience difficulty in organizing their lives. Would you talk about why that would be so?
Well, we see this even with, and you see this in the full spectrum of head injury, from mild all the way to severe, where they have problems in terms of executive functions. And those are in terms of planning, of anticipating things, planning for them, and then executing them. And in executive functions, you have not only being able to predict things and plan things, but also your memories involved. So there are a number of parts of the brain involved that need to come together. And for whatever reason, traumatic brain injury disrupts that. So you have tremendous difficulties in concentrating on a task and following through with it for a period of time. Or even just planning, like if you want to cross the street, there's a very good example. You got to know that this car over there is going to be over here, and then when you walk, what your timing is going to be, and anticipating that can be a big problem. Yeah. Because a lot of the brain functions responsible, and they usually attribute it to the frontal lobes, the front part of the brain, but I think we're now getting into this more than just the frontal lobe. There's a systems approach. There are systems involved in coordinating multiple parts of the brain to work together, and that's what's disrupted in traumatic brain injury.
We have a number of survivors of brain injury in our audience today, and we have some seated at the front table. And I want to take a few minutes to see if any of you have questions that you'd like to ask at this point.
I'm a brain injury survivor for 10 years now, and one of the major problems is in regard to the executive functioning. And what I wonder is, how can we explain to our doctors, our physiatrists, and just our families and friends why it is that we seem to have Alzheimer's at some time, why we have such trouble organizing. Can you give us a way to help educate other people that they can understand?
Well, you look normal.
That's part of the problem.
That's exactly the problem. We're very concrete. We look at people and say, you look normal. Why don't you act normal? And somehow we have to be able to, for instance, my older sister's retarded. She looks normal. So it's very hard for people to understand how you can look normal but be abnormal. I mean, if your leg is in a cast, I can understand why you're not walking. But I can't see your brain and the way it works. And I think there are a number of problems. I think that we need to have better descriptors, better language to describe the brain that the public can understand. A lot of the terms that come out are understandable to scientists or doctors, but they're not understandable to the public. So they need some kind of language that they can understand and then relate to it. So I think we're deficient in that. Executive planning and concentration and memory are very abstract terms that are difficult to convey to the public. And I think that we need to improve our language and terms to be able to communicate better with the public. Until that's done, I think it's a big problem. I mean, if our brains were outside our skulls and you could see damage or something, maybe they could point to it and say, yeah, I can see you have problems. But as long as you need an MRI or an fMRI or a PET scan or something else to demonstrate on a pretty picture, you know, what it is, and even that is suspect whether it really demonstrates the problems you have. It's going to be very difficult.
I had a brain injury about 7 years ago, and obviously what happened to my brain injury is all over. So I'm wondering if there's things I can do now, like is there some kind of way I can get more oxygen in my brain now that'll help it?
The main thing with the oxygen problem is early on, right after the accident. And because people, if you look at people in coma from an accident, 40% of them aren't breathing properly, they're not getting enough oxygen. So I think normalizing oxygen is good. Sure that if I put an oximeter on you right now, your oxygen levels are perfectly fine. So there's no proof that increasing the oxygen levels or increasing the oxygen pressure improves function.
I've heard a number of brain injury survivors express anger at physicians who tell them that, you know, that their growth or their improvement has stopped. Mm-hmm. Have you experienced that, those comments?
I can't comment because it's such a wide area, and
sure.
Obviously age has an impact. Age definitely has an impact, and unfortunately, over the age of about 60, we don't make as good a recovery as under that. Now, it's not like you turn 60 and suddenly things change. It's a gradation, say from like 45 through 65 through 70, somewhere around there. There's a gradation where your brain doesn't compensate from injury as well as it does when you're younger.
What exactly causes the swelling of the brain after a trauma? And specifically, what procedures relieve that?
Well, generally it's thought that the brain swells because of leaky blood vessels. What happens is the brain gets smacked and certain chemicals get released. And in the blood, there's blood and water. And basically the water from the blood vessel gets into the brain and the brain gets swollen. It's just like if you bang your fingers, your finger gets swollen or whatever part of your body gets hit. And it's mainly from the blood vessels becoming leaky and water goes out into the tissue. Now there's a reason for that. It's because so the white blood cells can swim around and get rid of all the foreign material or dead tissue, basically scoop it up. But to produce a swimming pool for these little cells, you end up swelling the tissue. And in the brain, it's not a really good idea because you've got the skull, it keeps it in. So one of the things we're starting to do more and more, it used to be done 20, 30 years ago, but now it's being done, I think we're getting better results, is you actually take parts of the skull off and allow the brain to swell. And in some cases, not all cases, and of course, I don't want to generalize apart therapy, every case is different, In some cases, the brain swells and goes back down, and you can get a good result. So it's probably leaky blood vessels. There are a lot of chemicals released after an injury, and they can cause not only the leakiness and the swelling, but also direct damage to the tissue.
It seems like monitoring brain pressure would be so obvious. Is it universal practice?
No, it's not. And it's not I think, for a number of reasons. I think one is it requires a lot. Once you put in a brain pressure monitor, you get a number, and it requires a lot of intensity of work, both from the nurse and the physician. And frankly, if you're not in a real trauma center that sees these patients all the time, you're not used to it, and it takes a lot of time. And frankly, trauma has a very low reimbursement. In spite of the fact that all these doctors and nurses are working day and night, 3 o'clock in the morning, some kid comes in, the hospital, the doctors, the nurses, the reimbursement is nil or very, very low. And so frankly, a lot of trauma centers close because they lose money. And here you're talking about the young people of our society. And so we got to change the reimbursement to attract physicians and nurses and hospitals to this area, because it's a leading cause of death and disability. What happens if you don't do the right thing initially? You end up with a 25-year-old kid who has severe brain damage that somebody's going to be taking care of for the rest of their life. It's usually the state, usually the taxpayer that goes on Medicaid. So yes, it's a problem in that we don't have routine monitoring, and we did the survey of the trauma centers in the United States, and we found that 2/3 of trauma centers don't routinely monitor brain pressure. Now, a lot of those are small hospitals in general, and the solution is probably not to take the patients there, take them to the larger trauma centers and have the reimbursement and financial incentives for those trauma centers to operate and take proper care.
I'd like to see if there are more questions from anybody in the audience.
I had an aneurysm 10 years ago. Of that, I had aphasia, language, and of that had the vasospasm on that going through with me in terms of like the listening, talking, reading, and writing. It's been tough, very tough. Usually I know the listening, talking is great, couldn't say the words. But after that, for me, learn and learn and learn again. How can other people, maybe within the 6 months, next year, or 5 years later, can help with this at this time?
Right. Well, from what you described to me, I don't know your case in detail, but you have what happened was there was a lack of blood supply to a very specific part of your brain responsible for generating words. And as opposed to other patients that have systems problems, you probably have a very focal problem with getting words out.
Yes.
And so the rest of it's all intact. It's just that one part that's a problem. And there have been a lot of, and I'm not an expert in rehabilitation, but I've read a lot about it and kept up with the progress. And it seems that there are a lot of rehabilitation interventions that could be done early on, and that can work around those areas. Obviously, there's sometimes where the function is just totally taken out. There's nothing you can do. But there is what we call plasticity of the brain. The brain can relearn, and so on. And it seems like you've done a good job of doing that. But it's a contrast I'd like to make to the lay public, is that there's a very focused deficit, which you seem to have, and you're getting over it. And then there's a systemic or global problem, what we see in traumatic brain injury, where multiple systems are involved, not just one small system.
If you would, comment on some of the applications of stem cell research on the brain and brain plasticity.
It's a very exciting area, and my question to I'd put a question out to you and the stem cell people, is exactly what are you trying to achieve? I think we all intuitively think that these cells are going to go in and make more of me better. And I think we got to re-examine, what's the outcome of this? Is it to increase IQ? It could be bridging torn spinal cord neurons, like for Christopher Reeve, for instance. It could be, is it for stroke patients that can't move an arm? You're going to put the cells in and you'll be able to move your arm. Is it people who had frontal lobe injury and suddenly they get executive functioning back? I don't know. I challenge them to say that a lot of what we do on a cortical level, on very complex cortical levels, are at the synaptic level. They're the little nerve ending levels, and those are built up over your whole lifetime. So you put in some new cells, is that suddenly, you're going to take a lifetime to build up those same connections? Or what happens? So I think there's an intuitive hope, and then there's a reality. And I think we got to balance the two. It's like one of those things that comes out, you say it's an answer to everything, and after a while you realize there's a narrow kind of usefulness in that. And we got to find out what that is. So far that hasn't been demonstrated.
I'm curious what drives you to do this work. Obviously, you've dedicated yourself to this, and you go beyond any sort of normal practice to do public service work. What drives you to do that?
Same drive as for you. It's for all of us sitting here. Well, I think that I think we're here because we're all connected as part of society, and if we can go through our life and make the lot a little better for everybody, we should do that. And if you've got some talent, and you should apply it. I mean, I was always interested in how the brain works, maybe because my sister's retarded, so I was always trying to figure out how to make her better. And I just found neuroscience to be, it's who you are. Your brain is who you are, and it's the ultimate challenge to understand how it works. So for me, intellectually, it's extremely interesting. And then when I started doing research in traumatic brain injury, I realized that it's a huge public health problem. Whereas I wanted to do research, and I was interested in the intellectual challenge of the chemical reactions and brain metabolism, brain chemistry, and all that. But then I was trained as a clinician. And as a member of society, I really wanted to make a difference. And I had the ability, because of the Brain Trauma Foundation, to affect change. I mean, I'm not intellectually challenged by telling people to put a brain pressure monitor in their head, monitoring pressure. It's not exactly intellectually stimulating. But if that's what makes a difference in the long-term outcome, that's where I am. I'll be there. So, so that's where I am. I'd like to get this thing solved so I can do something that's really stimulating, which I'm starting to do now, hopefully, but it'll also have an impact on patients.
Well, on behalf of all of the people you've helped, thank you very much. And thank you for coming to San Diego and being with us.
Thank you for inviting me.
Thank you for joining us today. If you would like more information, please click to our website at www.sdbif.org or call us at 619-294-6541.